Good morning, ladies and gentlemen. Today, I'm very happy to have one of our stars in cardiology community, Dr. Khidir Dalouk. He's a famous and known electrophysiologist. This branch, which we lack here in Sudan, and actually, Dr. Khidir helped the Sudanese people a lot during his journey between United States of America. He come regularly to teach and to do a lot of procedures like pacemaker implantations, ICD implantations, ILR implantations, and a lot of services in this field. We hope that Dr. Khidir we can have some specialty here in Sudan to have more EP physicians to treat our people. Dr. Khidir is an excellent and distinguished electrophysiologist, and he's an assistant professor of medicine. And he is going to talk this morning about supraventricular tachycardia. Dr. Khidir, I'm very glad to have you here in this platform. Please welcome.
Thank you. Thank you very much, Dr. Disugi. It's a pleasure to be with you this morning. Assalamu alaikum, everybody. My name is Khidir Dalouk, as Dr. Disugi has introduced me. I'm an electrophysiologist here in Oregon, Portland, Oregon. Portland is the city, and Oregon is in the northwest of the United States. I graduated from University of Khartoum. And did my internship and housemanship in Sudan, and then my journey went to Ireland before I came to the US. Did my residency again, and did my cardiology fellowship and EP electrophysiology fellowship at Oregon Health and Science University Hospital, where I stayed as staff after graduating from my fellowship. I would first like to thank you all for the invitation to do this talk, and I would like to thank you all for being in Sudan at this very difficult time. What you guys are going through and doing for our families and our country is something that is just beyond imagination, and your reward is in Allah subhanahu wa ta'ala. I hope you guys are all safe and your families, and may Allah save our country, bismillah. So I'm going to start, my talk is going to be about supraventricular tachycardias. I don't have any conflict of interest. The talk will cover an introduction, some definitions and epidemiology, mechanisms of SVT, and then we'll go through the three main SVT tachycardias that fall under this umbrella. And then we'll go through some clinical scenarios. As the name implies, supraventricular tachycardia is a tachycardia that comes above the junction, and it's an umbrella term that describes any tachycardia, whether it's an atrial or ventricular rate in excess of 100 beats per minute. The mechanism of which involves the tissue from the His bundle and above. So you might imagine that, it encompasses, sinus tachycardia, it encompasses AFib, flutter, but we consider atrial fibrillation and atrial flutter as different entities. They don't fall under the umbrella of SVT. And sinus tachycardia is physiological, so we don't consider sinus tachycardia under this umbrella. But of course, things like inappropriate sinus tachycardia, there is something called sinoatrial re-entrant tachycardia. These are all tachycardias that come above the junction. But really, when we're talking about SVT, we are talking about the three SVTs that I'm showing you up here on the image. The most common is AV-NRT and AVN, as we will see in a few slides. AVN is the abbreviation of the AV node. And if the tachycardia is a re-entrant tachycardia, this is the RT that you see. ORT is related to an accessory pathway, and the circuit involves the atria as well as the ventricle. And that's why the name is AVRT, atrioventricular reentrant tachycardia. And then the last one is an atrial focus, a group of cells that are starting to fire. Sometimes it's a micro reentrant circuit, and sometimes it's a macro reentrant circuit of atrial tachycardia. So these are the three main subgroups that we will be covering today. The prevalence of SVT in the general population is about 2.25 per thousand persons. In the United States, there are about almost 90,000 new cases per year, and there is more than 500,000 persons with PSVT. PSVT stands for paroxysmal SVT because these rhythms tend to come and go, and that's why they get the name of paroxysmal SVT or PSVT. And in the US, there are about 50,000 ER visits each year in the United States, for SVT, and that is an enormous amount of people coming to the ER and a lot of budget that goes into it. Unfortunately, the epidemiology of arrhythmias and different things in Africa and Sudan is not well documented, and I think documentation is very important. So I think if we, inshallah, al-balad al-afa, we will hope to have a registry that can, shed more light about the epidemiology of those arrhythmias. Individuals above 65 of age have almost 5 times the risk of younger people to have PSVTs. Some people think that it's a disease of the young, but this is not necessarily true. I think sometimes there is a referral bias, single population ACLR PSVT in this age group of above 65, and older. Overall, the mechanisms of arrhythmias, not just even for SVT, it's overall 3 different mechanisms, and this encompasses, all kind of arrhythmias. And abnormal automaticity is one, and everything goes back to physiology. This is the action potential, if you will. You see it here of the Purkinje fiber. This is phase 0, phase 1, phase 2, phase 3, and then phase 4. So that is the hallmark of going back to physiology and understanding arrhythmias. If you have a group of cells that are automatically firing, an example of automaticity, of course, is the sinus node. But there are cells that are abnormally firing. Dr. Omar, if you don't mind muting yourself, that would be great. I'm hearing an echo. So abnormal automaticity is a group of cells that are just firing and they're an automatic focus. The other group of, or the other mechanism is what is known as triggered activity. As you can see here, I'm not sure if you can see my cursor, but this is the action potential. And there is almost like a focus that is starting to depolarize early during phase 3 of the action potential, and this is called early after depolarization. If the focus of depolarization happens in phase 4 during the resting membrane potential, this is called delayed after depolarization. So early and late, or early and delayed after depolarizations are examples of trigger activity. And the most common is related, for example, to digoxin toxicity. Digoxin toxicity is very notorious of causing those after depolarizations. The most common mechanism is re-entrant tachycardia. And in re-entrant tachycardia, there are anatomically 2 different tissue with different properties in terms of conduction velocities, in terms of refractoriness, and there is usually a gap. There is a head to the tachycardia and a tail, and there is a gap, and the tissue and the circuit circulates around. So this is the most common, and most of the SVTs are, as you can see, 2 of them are re-entrant. The atrial tachycardia can be any of those 3 mechanisms. So these are the 3 mechanisms again. Enhanced automaticity, triggered activity, and reentry. And automatic foci or foci, if you will, are an example of enhanced automaticity. Of course, if it's normal, the example is sinus tachycardia, but if it's abnormal, the example is atrial tachycardia. And usually those tachycardias have a warm up and a cool down phenomena, if you will. They start, gradually warm up, speed up to the, tachycardia, cycle length or rate, and then they cool down. It's not just very abrupt initiation and termination. At least this is the automatic form of atrial tachycardia, which is the most common in this group. SVTs can encompass any of those that you see here, but as I said, if you take the definition of SVT literally, it's mainly focusing on the 3 tachycardias that I showed earlier on the slide. In any tachycardia, of course, as you know, tachycardias can be narrow complex tachycardia or wide. The definition is based on a QRS of less than 120 or more than 120 milliseconds. There are tachycardias that are regular, and there are tachycardias that are irregular, of course, and that can classify the tachycardias, or dichotomize the tachycardias into those 2 groups. Over here, we're going to be talking about focal atrial tachycardia. We're going to be talking about AV-NRT and AVRT. These are the 3 SVTs that mainly when we're saying SVT, we're concerned about those 3. But any tachycardia above the junction can fall into that. And that's why you will see things like inappropriate sinus tachycardia, sinonodal re-entrant tachycardia. Atrial flutter, as I said, it's above the ventricle, but it's a different entity. That's why we do not lump it under SVT. Sometimes you might get a junctional tachycardia. You might get, a narrow complex tachycardia, which is not, an SVT. It's actually VT, but you can get fooled, with some idiopathic VTs that are coming from the fascicles. And these are usually very narrow tachycardias. I'm not going to focus on wide complex tachycardia. We'll have a different talk about that. Inshallah, a different session. These are the main tachycardias we're going to be talking about. The most common is AV-NRT, occurs in about 65% of, SVTs. Orthodromic atrioventricular re-entrant tachycardia occurs in about, less than 30%. And atrial tachycardia is the, least common, occurring about 5%. In general, we do classify SVTs into short RP tachycardia and long RP tachycardias. During SVT, sometimes it's very difficult to see the P wave, if you can see a P wave. But if you do, depending on where that P wave falls, if you imagine this is the QRS here, the QRS, and if you make a line between the 2 RRs, if that P wave that you see is in the first half, then we call that, a short RP tachycardia. If the P is falling into the second half of that interval, we call it a long RP tachycardia. In general, I don't think this makes a lot of difference for you in clinical practice if somebody comes to you with SVT, but for us in electrophysiology, it does help us prep the procedure when we're taking those patients to the electrophysiology lab to do an EP study and to do an SVT ablation. The hierarchy of, the differential is a little bit different, if you have a short RP tachycardia compared to a long RP tachycardia. As you can see here, short RP tachycardias, are on your left side, and on your right side, these are the long RP tachycardias. AV-NRT tends to be the highest, if you have a short RP tachycardia, and if you can measure the initial part of the R to the P, if that interval is less than 90 milliseconds, the typical form of AV-NRT, the sensitivity and sensitivity of this measurement is very high for typical AV-NRT. If you have a short RP tachycardia, but that R to P interval is more than 90, falling into the ST-T segment, it's most likely this is an accessory pathway related tachycardia or AVRT. And usually if it's a long RP tachycardia, the odds that it's a focal atrial tachycardia is the highest. So this is where this distinction between short and long RP tachycardia comes into play. As you can see here, this is a narrow complex tachycardia. This is the algorithm of how you approach this. Of course, any tachycardia, not just SVT, if the patient is hemodynamically unstable, they should be cardioverted. If you have time, the patient is stable, First thing you start by is by doing vagal maneuvers, and there are different ways of doing vagal maneuvers. I think the best thing to do is to ask the patient to blow and hold their breath. And once they do that, they lay down pretty quickly and they lift up their legs. This is called the modified vagal maneuver. There's a randomized control trial that was done in the emergency rooms in the United Kingdom, and they randomized people to the routine vagal maneuver versus the modified. And people tend to, terminate, higher with the modified vagal maneuver. So I think this is something that we can do in Sudan. I think we don't have a lot of medications available. So I think learning how to do the modified vagal maneuver, I think, is very important. If vagal maneuvers don't work, then your next step is to give IV adenosine. IV adenosine is a very short-acting medication. The half-life is a matter of 3 to 6 seconds. Usually, patients have to have a big bore IV. The medication should be given very, very quickly through the IV, and is followed by an IV flush. The response to adenosine can vary. It really depends on whether you gave the right dose, whether you gave it quick enough or not. And sometimes if you don't give it quick enough, then you might not get the result that you want. But we do expect that if it's an SVT, it can terminate, especially if it's, most of those tachycardias are related to the AV node, especially two of them, AV-NRT and AV-RT. Atrial tachycardias, some of them can terminate with adenosine, some of them might not. If the rhythm sometimes is atrial flutter with 2-to-1 conduction, the heart rate is 150. Sometimes you might not be able to differentiate SVT from flutter, just based on the ECG. You might need to do the vagal maneuver so that you increase the level of block in the AV node, and that will allow you to see the flutter waves. If you give adenosine and the rhythm does not terminate, but at least you got a diagnosis that this is not flutter, you can give either IV calcium channel blockers or IV beta blockers. I have used the European guidelines because I think our system is similar to the Europeans more than the Americans. This is the adenosine response, as I just mentioned it. You might not have no effect, and that might be because of the inadequate dose. Sometimes it might be that the adenosine is not working because the rhythm is actually a fascicular VT and it's not an SVT, or it might be one of those atrial tachycardias that are not adenosine sensitive. If the rhythm gradually slows and then reaccelerates, really does not help you a lot. It could be sinus tachycardia, it could be automatic focal tachycardia, it could be a junctional ectopic tachycardia. If sudden termination happens, then AV-NRT, AV-RT are your top on the differential if the rhythm terminates with adenosine. Those are less common tachycardias. Sinus nodal re-entrant tachycardia is a very rare entity. I don't think we see it enough. If you imagine that there is a circuit within the sinus node itself, there is a circuit within the sinus node, and it exits the sinus node to activate the atria. It's very hard to differentiate from sinus tachycardia. I think the only way you might be able to differentiate that from sinus tachycardia or an atrial tachycardia close to the sinus node, we call it crista terminalis atrial tachycardia, is if you have telemetry. If you see the telemetry, you will see that, boom, there is abrupt initiation of tachycardia and boom, abrupt termination. The P wave morphology is going to be very similar. If you see a P wave, it's going to be very similar to sinus tachycardia and very similar in morphology. So you're not going to be able to differentiate based on morphology. The telemetry is your only way to differentiate those crista terminalis atrial tachycardia and sinus nodal re-entrant tachycardia from sinus tachycardia. If the rhythm persists, but you're able to see flutter, or you're able to see a macro re-entrant atrial tachycardia, you will see P wave. They're not sinus, and this is usually a macro re-entrant tachycardia. I'm just going to say a few words about inappropriate sinus tachycardia. The definition is about sinus rate more than 100 beats per minute at rest. with a mean of 24-hour heart rate of about 90 beats per minute or above. And usually you should, this is a diagnosis of exclusion. Of course, you should rule out, things like anemia, cytotoxicosis, the patient does not have a PE, all of the above, all of the things that can cause secondary causes of sinus tachycardia should be ruled out before you make that diagnosis. There is a medication called ivabradine. It's a potassium channel blocker that has a higher indication for inappropriate sinus tachycardia compared to beta blockers and calcium channel blockers. As you see here, this is the European guidelines. Ivabradine has a class 2A indication, beta blockers, as well as a class 2, but there is more data with ivabradine compared to beta blockers. Let's jump to the meat, as they say. So AVNRT, as the name implies, AVN is the abbreviation of the AV node. And since the tachycardia is re-entrant, this is the RT. And most people are born with one kind of highway leading to the AV node. 10 to 15% of the population have what we call dual AV node physiology. And, you will see that on the next slide here. There are two forms of this AVNRT, which is a tachycardia related to the AV node. Some people simplify it that the circuit is inside the AV node. It's not exactly that. There are two, inputs to the AV node, if you will. So one is a fast pathway and one is a slow. As I said, 10 to 15% of the population have dual AV node physiology, but not all 10 to 15% of the population develop AVNRT. You have to have the right setup of, some sort of catecholamine surge that happens at the right time that allows this circuit to happen. But there is a typical and an atypical form of AVNRT. The typical form is the most common in 90%. Atypical form is less than 6%. And I'm going to explain more about, slow, fast, and fast, slow in the next slide. So this is, a diagram. They, call this the donut diagram. And, it is showing the two pathways that I just described. There is a fast pathway and a slow pathway. The zigzag line is showing you that the conduction velocity is slow, and the straight line is showing you the fast conduction. Fast is referring to the conduction velocity, and slow is referring to the conduction velocity. So there are two different kinds of tissue with different properties, fast conduction and slow. Any conduction tissue, in addition of having the conduction velocity, the conduction system has refractory periods, meaning that the tissue needs to wake up before accepting another beat. So if you imagine that a sinus beat comes from top, it will go down both pathways, but it will go very fast down the fast, down to the ventricle. And it will even go down, circulate around the slow. And there is another waveform coming down the slow, and those will collide. So there will only be one beat that goes and activates the ventricle on the left side. If you imagine that there is a premature atrial contraction coming right away after this sinus beat, it will come down and it will find the fast pathway refractory. Because I told you, if the fast conducts very fast, but it's very slow to recover from refractoriness. So this PAC will find the fast pathway refractory, so it will not be able to propagate. It will come down the slow, very slow, 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 slow. It will go down the ventricle. And by that time, the fast arm had recovered from refractory. This beat can go back and activate the atria again. So if this PAC goes down the slow and up the fast, this is what we mean by typical AVNRT. This beat goes down the slow and up the fast, and you will be activating the atria and the ventricle at the same time. One beat will go down to the ventricle, but it will echo back to the atria again. The opposite is true. If you're going down the fast and up the slow, this is the atypical form of AVNRT. And you can imagine here that if you're going down the slow, so it will take more time to go down the slow down to the ventricle, you know, you will echo back right away because that fast track will conduct very fast back to the atria. So you will go down the slow, up the fast. And that is a short RP tachycardia. For the long RP tachycardia, you go down the fast and up the slow. So the P wave that goes back to the atria will fall, late. So that's an example of a late or a long RP tachycardia. A lot of you might not be familiar with this, but this is what we do in our EP study or electrophysiological study. This is a right anterior oblique angle, and the right side is the right anterior oblique. I'm not sure if it's showing up nicely there for you guys. This catheter is in the right atrium. This catheter is in the right ventricle. The CS is the coronary sinus catheter. And then there is the HIS catheter, very close to the intraatrial septum, close to the AV node. In the left anterior oblique, the catheters are coming toward you, at least the right ventricular catheter and the HIS catheter, and this is the right atrial catheter. These are the electrocardiograms from those catheters. So as you can see on the top, it's usually an ECG. This is AVF and V1. This is the high right atrial catheter. And anything that lines up with the P wave is an atrial signal. And if everything that lines up with the QRS is a ventricular signal. This is the HIS catheter, and this catheter will give you an A HIS signal, and a V. The coronary sinus as well will give you an atrial signal and a ventricular signal, and the right ventricular catheter will only give you a right ventricular signal. So this rhythm here is sinus rhythm, and it makes sense because the high right atrial catheter is very close to the sinus node. So that's why it is the first EGM. If I draw a line, you can see that the high right atrial catheter is first, then the HIS, then the CF. So it's slanting this way. And this is sinus rhythm. And what we do in our electrophysiological studies, we pace the heart from the atrial catheter, from the ventricular catheter. We see how signals go down to the ventricle. We pace from the ventricle, and we see how things go back, retrogradely to the atria. And here we're doing a pacing drivetrain. We usually choose, what we want to do. So these are like 6-8 beats with a cycle length of 500. And then these are like almost premature atrial beats, just like PACs. We are causing those PACs. We're giving another one at 280 milliseconds and another one at 280 milliseconds. And you can see here, the way you know that you are pacing from these catheters is by that square root sign. You can see that I'm pacing from the high right atrial catheter. And what I want to show you here, you can see this interval here is called the AH interval, atria and the HIS. This is the AH interval. It's almost like the PR interval, if you will. And you can see here the AH interval, prolonged. It jumped, and here you went down the slow pathway, down to the ventricle, and you echoed back to the atria. And you can see here the HIRA was activated right at the same time as the QRS. That cannot happen unless you have dual AV node physiology. There is no way for a beat to go down to the ventricle and another beat goes up unless you have dual AV node physiology. Because if the AV node has only one pathway and going down, there is refractory period. Nothing can go back. It will take a lot of time for it to go back. The only time when you have an A on V tachycardia, this is called an A on V tachycardia, is if you have typical AVNRT. And you can imagine here that the P wave in the surface QRS is falling at the very terminal portion of the QRS. But in the EP study, we're able to see that because we have catheters inside the heart. So we can see where that P wave echoes back. And it's not very easy to see sometimes on the surface ECG. So this is a sinus ECG. There is sinus rhythm here. You can see the P waves upright in 2-3 AVF, and there is one-to-one conduction. I think a key to SVTs, always pay attention to the terminal portion of the QRS and pay attention to the T wave. Look how they look in normal rhythm and look how they differ during tachycardia. And this is your clue of where to find those P wave. So this is an example of a narrow complex tachycardia. It's very fast, but this is the same patient I just showed you. And you will notice here on V1, this didsel here was not there before. If you can see here, this is sinus, you don't see that, right? But during tachycardia, you see that there. Similarly, in lead 2, here at the end, this is called a pseudo S. I'll go back and you can see here, it was not there. But now during tachycardia, you can see it. So this is an example of a short RP tachycardia. The P wave is here. These are the P wave. You see it here as well in AVL. You see it here in AVR. If I go back, you will see that these didsels were not there before. And this is where the P wave is hiding. And if you measure from the beginning of the QRS to this P wave, that interval is less than 90 milliseconds. And as I told you, this is just an arrow showing you where the P wave lies during SVT. As I told you here, if that R to P is less than 90, your top differential is typical AV NRT. Okay? All right, so I'm going to skip that. There are measurements similar to this 90 milliseconds on the ECG that we do during an EP study. It's called the VA time. And this is the duration from the initial part of the QRS to the earliest P wave that we see on those catheters. And usually this catheter, the His catheter, is in the septum. So if you measure the initial part of the QRS to the A in this His catheter, and if that duration is less than 70, this is one of our diagnostic maneuvers that we do in the lab to confirm AV-NRT, and then we proceed with ablation. In typical AV-NRT, this has been studied, this R prime in V1 has been studied, and it has a high specificity sensitivity for diagnosing typical AV-NRT. There is a Spanish group that looked at AVL, and as you can see here during tachycardia, you see that didsel there. And AVL, AVR, going back, AVL and AVR have a very high sensitivity, much more than lead V1 and lead 2. So if you see that, you can clearly tell the patient you have AV-NRT. The sensitivity and specificity is more than 90%. It's more than 95%. So you're very you can be very sure that this is AV-NRT. This is an example of a long RP tachycardia. You can see the RRs, and here the P wave is falling into the second half of that RR interval. And, as we said, if it's a long RP tachycardia, your top differential, this is atrial tachycardia. This is the, diagram that will show you, what to do with an SVT. I think they're all the same. For treating an SVT, we start by, are they hemodynamically stable or not stable? And then we go for vagal maneuvers. You give adenosine, and then, for the long-term treatment, those patients can, be given beta blockers or calcium channel blockers in a pill form. But in places where, there is an EP lab, these are, arrhythmias that we can cure. There are very few things in medicine that we can cure, but we're just not fortunate in Sudan to have an EP lab where we can just cure those rhythms. There is a lot of people with SVTs, and inshallah, and one day we'll have that technology in Sudan. These are what we call 3D maps. I just wanted to show them to you so that you can know what we do. This is a computer model that builds up geometry of the any chamber that we are on with those catheters. The EP lab table have magnets at the very bottom of it. The patient will have pads in front and back, and the catheter's tips have magnets, so we can move the catheter, and the catheter will build geometry even of the blood vessels as we're going up the venous system, we can use that to minimize the use of radiation. But we will build up those maps, and those maps can give us a voltage map. It can tell us what is healthy tissue, what is scar, and it can also, during tachycardia, we can tell, are we close or far from the tachycardia, and it will form what we call an activation map. The red dots that you see here, these are where we did the ablation. This is the area where we ablate the slow pathway. So in AV-NRT, we ablate the slow pathway because you have two pathways, fast and slow. We only need the fast, so we usually get rid of the slow pathway. And anatomically, they're different. They're not in the same spot, so that's why we can do that. Very rarely you will have a 1% risk of causing AV block. If those two highways are very close to each other, you might cause AV block, and of course, some patients might end up with a pacemaker. But the risk of that is very low. Very rarely that we elect to do medical therapy rather than go the route of doing an EP study here in the United States, and I think in Europe and Asia. Very rarely that we would use antiarrhythmic drugs to suppress SVT, as I said, because these are overall curable rhythms. I think the key to tell your patients is that this is not a life-threatening rhythm. This is a benign rhythm. It's not going to cause you to drop dead. It's not going to cause a heart attack. It's scary for the patients, but I think reassurance goes a way to tell them that overall this is a benign rhythm. Teach them how to do vagal maneuvers. I think this is a key thing for Sudan. And I think if vagal maneuvers don't work for them, they can come, of course, to the emergency room. They can get adenosine. But I think being on beta blockers or calcium blockers, I think work in a lot of people to suppress, SVT, especially AV-NRT. This is another example of a patient who came in with palpitations. This is an error complex tachycardia. The rate is almost 150. If you divide, 300 by the big boxes, this will give you the rate. And as you can see, there are small dead cells, here at the very end of the QRS here in AVR. So this is another example of a short RP tachycardia. So here, what is the likely diagnosis? The likely diagnosis is typical AV-NRT because this duration here, from the beginning of the QRS to the P wave, is less than 90 milliseconds. Okay. ده ابن كريم داير يشارك في المحاضرة. This is the normal ECG of this patient. As you can see, I just wanted to show you that the dead cells at the end of the QRS are not present. We will go now to AVRT, and as the name implies, it's atrioventricular reciprocating tachycardia, AVRT. And these are pathway-related tachycardias. Accessory pathways are usually falling between the A and the V, usually at the base of the heart, and they can happen or occur on the left side of the heart. They can happen on the right, the left. They sometimes can be on the septum. They are known as WPW, Wolff-Parkinson-White, but also the other name for that is pre-excitation or delta wave. So any tachycardia that involves an accessory pathway, it can go down the AV node and backwards through the accessory pathway, and it forms a circuit. And the atria and the ventricles are a critical part of that circuit. The circuit cannot maintain itself without the atria and the ventricle. So if you see an ECG and there is AV dissociation between the A's and the V's, this cannot be AVRT or WPW syndrome. It has to have the A and the V inside that circuit. Tachycardia is related to accessory pathways. In general, are dividing into ORT. And the names, there are several names for this ORT. So it's orthodromic atrioventricular re-entrant tachycardia, or we abbreviate as ORT, just orthodromic reciprocating tachycardia. And in that form, this is the form that has a narrow complex tachycardia, because your wavefront is going down the AV node and it's going backwards through the accessory pathway. anytime you go down and engage the normal conduction system, your QRS will be narrow. So that's why this tachycardia is narrow, because you're going down the conduction system, you're going down the bundles, you're going down the Purkinje system, but you're going backwards through the accessory pathway to activate the atria and forms that circuit. In antidromic tachycardia, this is in the differential of a wide complex tachycardia. This is not in the differential of a narrow complex tachycardia, because here the wavefront is going down the accessory pathway and backwards through the AV node. Okay, so this will give you a wide complex tachycardia, and the reason is there is no conduction system, there is no Purkinje fibers in this area. This is, the wavefront has to go through muscle to muscle to muscle to muscle till it will find the bundles and go back to the AV node. Similar to VT, the way VT is wide is because it does not engage the conduction system, it engages the muscles of the heart, and that's why it's wide. So this is part of the differential of a wide complex tachycardia and not a narrow complex tachycardia. This is an example of ORT. As you can see here, the arrows are showing you the P waves. And this is an example of a short RP tachycardia, but the duration between the initial part of the QRS to the P wave is more than 90 milliseconds. So if your P wave is falling within the ST segment, your likely diagnosis is going to be ORT rather than AV-NRT. Okay, and this is just what we said. ORT is the most common, 90 to 95%. ART, which is a wide complex tachycardia, is very rare. So this is what you will see in an SVT or a narrow complex tachycardia. And I think the key to remember, in ORT, if somebody comes in with an SVT and you don't know, of course, whether they have an accessory pathway or not, it's okay to give metoprolol, adenosine, digoxin, all of the above. The main time when these drugs are contraindicated to give in somebody with an accessory pathway is if they are in atrial fibrillation. If you have atrial fibrillation and an accessory pathway, those two, we call them pre-excited atrial fibrillation. The delta wave, the other term for it is pre-excitation. So if you have pre-excited AFib, this is the time when you cannot give adenosine, you cannot give beta blockers, you cannot give calcium channel blockers, you cannot give digoxin, and also you cannot give amiodarone. Amiodarone is contraindicated in pre-excited atrial fibrillation. We can use antiarrhythmic medications for ORT, but as I said, these are very amenable to ablation. I think in your case, if you see somebody with WPW, I think it's if they don't have AFib, it's safe to put them on beta blockers and calcium channel blockers. If they have AFib, then I think we're in trouble because they might get pre-excited AFib and it's contraindicated to use metoprolol, calcium channel blockers, and digoxin. Even oral amio is actually contraindicated in pre-excited AFib. So this is a telemetry tracing. This is lead V5, this is lead 2, and this is an example where I showed you that the trend will tell you, is this sinus tachycardia or SVT? So this is an example of an SVT. You can clearly see the abrupt initiation of the tachycardia. Here you can see there are P waves, and all of a sudden, there is initiation of SVT. So this is just an example that telemetrics can sometimes be very helpful. If you see an abrupt initiation of tachycardia, if you look at the heart rate trend, you will be able to differentiate sinus tachycardia from SVT. So this teletrip will show you that this is not sinus tachycardia because there is abrupt initiation. This is not ventricular tachycardia because it is a narrow complex tachycardia. VT is usually wide. And this is not accelerated idioventricular rhythm. AIVR is just a fancy name of slow VT. Supra-Ventricular Tachycardia is the diagnosis. Cannot tell based on the findings. No, we can definitely tell what is the diagnosis based on the tracing. All right, second, let me do that. Are you guys able to see my screen okay?
Yes.
So this is just the example. I'm just explaining to you that the tracings can confidently tell you this is an SVT and it's not sinus tachycardia. Okay, so this is an example of a 22-year-old female with episodes of palpitations. This is her ECG, and here in this ECG, you can see that the patient is in sinus rhythm. You can see the P waves. They are upright in 2, 3 AVF, and they're upright in lead 1. But you can see in some leads, and always, don't look at one lead. Always learn to look at all the leads, because you can see here in V4, for example, V5, V6, there is a very short PR interval. The PR is not normal. And you can see that there is a delta sign, right? This is the delta sign, or the, pre-excitation pattern, or the WPW pattern. All of those are the same name for just the delta. It was called delta based on the Greek alphabet. The Greek alphabet is a triangle, the delta alphabet. So it is showing up as a triangle. So that's why it was called a delta wave on the ECG. When the delta is showing itself on the ECG, we call this manifest pre-excitation, meaning that it's showing itself on the ECG. Sometimes you might have a normal ECG without a delta, but that doesn't mean that doesn't rule out that the patient have an accessory pathway. The patient might have a pathway. If we take them to the EP lab and discover a pathway, retrospectively, we will say this patient had a concealed accessory pathway, meaning that it did not show itself on the ECG, but we saw it in the EP study. If it's showing itself on the ECG, which is the most common, it's called manifest pre-excitation, or manifest WPW, or manifest delta wave. Having a delta wave on the ECG, this does not prove that the SVT that the patient came with is related to the accessory pathway. Sometimes the pathway is bystander, meaning that we do see a pathway on the ECG, we see it, on the EP lab, but the mechanism of the tachycardia is AV-NRT, or maybe atrial tachycardia. So that's why in the EP lab, we always, even if we see a delta pre-excitation, although likely this patient had an ORT, we have to confirm it in the lab. So it might be a different arrhythmia. And if we ablate the pathway and the arrhythmia was an AV-NRT, we have not solved the problem. So always we make those diagnostic maneuvers in the EP lab. This is another example of a patient with a narrow complex tachycardia. It's very fast, but you can see the P waves are almost within the the ST segment and T wave. And this is actually the same patient that I showed you here. So this is, as I told you earlier, if that R to P interval is more than 90 milliseconds, likely this is ORT. Likely. It's not diagnostic, meaning that, in medicine, everything can happen. So sometimes you will get, AV-NRT with that duration, but, playing the odds, ORT is your top differential. Based on the ECG and some kind of algorithms, we can tell where the accessory pathway is located. This is called the Arruda classification, to localize where the accessory pathways are. This helps us in the lab to set up the lab. Are we, planning for a right-sided procedure, meaning is this on the right atrium, or are we going to be planning for a transseptal and going to the left side? So these algorithms help us do that. This is an ECG that you should just stamp in your, memory. This is not an SVT, of course. This is a very irregular rhythm. So if you have an irregular rhythm, you should always think about AFib, right? Some of the QRSs are very wide, and some of them are narrow, and some of them are in between. So when you see that, and the rhythm is very irregular, always try to look at those narrow beats. And you can see in this beat here, there is a delta wave. So this is an example of pre-excited atrial fibrillation. And the reason you're having wide QRS complexes because, impulses from AFib on the left atrium are coming down the accessory pathway. And if you come down the accessory pathway, you're going to have wide QRS complexes. If you're going down the AV node, you will have very narrow complexes like those. And if you have two wavefronts, one coming from the accessory pathway, one coming from the AV node, and they collide, they can form the QRSs with in between narrow and wide. They're in between. They're almost like a fusion, beat. This is the time when it is contraindicated to give adenosine, digoxin, beta blockers, calcium channel blockers, and amiodarone. Okay. I think the differential is polymorphic VT, or if these are runs of VT. VT usually is not as irregular as this. And, I think the irregularity is what, gets you the diagnosis. Somebody might say, well, maybe this is AFib with just salvos or, runs of non-sustained VT. I think the clue is that it's very irregular. Usually non-sustained VT is regular. It is not irregular. Okay. I think we have a few minutes. So this is a pre-excited AFib. This is the time when you can give only IV procainamide, IV ibutalide. In Europe, they have IV forms of flecainide and propafenone. I think in Sudan, I think the main thing you can do is just to cardiovert those patients. This is just to show you that amiodarone is contraindicated. Everything is red is a contraindication. So this is contraindicated to give even amiodarone, which is, I think, the most common antiarrhythmic in Sudan. So the last group of SVTs are those atrial tachycardias. And this is just a group of atrial tissue that has the ability to automatically depolarize itself. And the rate of atrial tachycardias is usually between 100 and between 100 beats per minute to 250 beats per minute. Atrial flutter is usually faster, and this is the atrial rate. When I'm saying 100 to 250 beats per minute, I'm talking about the atrial rate, not the ventricular rate. Focal atrial tachycardias occur between 3 to 17% of patients with SVT, average about 5%. Most of the time they have a warm up and a cool down, phenomena if they're on automatic focus. Usually they are a long RP tachycardia, as we mentioned, and some of them can be re-entrant, and the re-entry could be a very small circuit, or it could be a big circuit. We call it a macro re-entrant circuit. These are things that we would diagnose in the EP lab. It's very hard to determine that based on the ECG. And those atrial tachycardias are most commonly coming from the right atrium, as you see here. 75 to 85% come from the right atrium, less so from the left atrium, but they can come from anywhere in the left and right. They can come from the SVC, they can come from the pulmonary veins or the coronary sinus. They can be originating from all those. And it's usually a long RP tachycardia, as we mentioned. I'm going to skip that because it's the same. I'm going to skip those two. I want to show you multifocal atrial tachycardia, is an irregular form of SVT. And the hallmark of the diagnosis is to see at least 3 distinct P-wave morphologies. And, this is what is shown here. So a lot of people can mix that with atrial fibrillation. But the key is that you're able to see P-wave, but the morphology of the P-wave is different. And if you see 3 different morphologies, this is multifocal atrial tachycardia. Most commonly seen in patients with pneumonias, COPD, or lung problems and pulmonary hypertension. If you see 3 distinct P-wave, but the rhythm is slow, this is by definition wandering pacemaker. Most of the time they respond better to calcium channel blockers rather than beta blockers. At least, based on the guidelines, they still have the same class 2A, but they tend to respond better to calcium channel blockers. I just wanted to show you that there is a very high success rate to ablation for AVNRT is 97, for accessory pathway mediated tachycardias is 92, and for focal atrial tachycardia is 85. Recurrence rate is overall very low. It's highest in atrial tachycardia, and complications from procedures like an EP study are very low, and mortality is very low. I think I'm going to stop here so that we can get time for questions. Thank you very much for your time, and I'm happy to take any questions.
Thank you very much, Dr. Khidir. Really يعني this is very interesting to have such type of talk in this platform. ونحن الحقيقة حزينين جدا يا دكتور خضير، بالرغم انه سعيدين يعني بسماعكم وبمشاركتكم، لكن حزينين انه يعني السودان لحد الآن يعني ما فيه السبيشاليتي دي والخدمة دي متوفرة للسودانيين. يعني أنا قبل 3 شهور عندي مريضة حولتها مصر عشان تعمل ابليشن ل SBT. ونتمنى إن شاء الله يعني في القريب العاجل يكون الخدمة دي إن شاء الله متاحة موجودة في السودان، ويكون في
بإذن الله.
تدريب للناس. المحاضرة دي يا شباب قدمها دكتور خضر. دكتور خضر هو